Welcome to the December 2025 educational event. I'm Kavya Velagapudi, Executive Director of the Neuroendocrine Cancer Foundation.
I'm Lisa Yen, Director of Programs and Outreach.
And I'm Heather Davis, the Director of Community Engagement.
Today's presentation is on the latest on immunotherapy for neuroendocrine cancer. A special thank you to our supporters, Novartis, Ipsen, Exelixis, Crinetics, Curium, ITM, Boehringer Ingelheim, Tercera, and InterScience Institute. Neuroendocrine Cancer Foundation, previously known as LACNETS, provides a community of support and education for neuroendocrine cancer patients and caregivers. Our staff includes Lisa Yen and Heather Davis. Our board includes Donna Gavin, who is the sister of our founder Giovanna Joyce Mbezi, and net patient Mary Dunleavy. Neuroendocrine Cancer Foundation partners with the Carcinoid Cancer Foundation to provide its programs, including the Luncheon with the Experts and the support line. Now I'll hand it over to Heather.
Thank you, Kavya. After Dr. Chauhan's presentation, he will answer general broad-based questions regarding immunotherapy for neuroendocrine cancer. Please note he cannot answer personal health questions or offer medical advice on your specific diagnosis. To submit your questions on our website, go to ncf.net/events/DEC2025. Again, you can submit your questions now or after his presentation at ncf.net/events/DEC2025. Now let's get started with some tech tips for ideal audio and visual quality. For audio, ensure your volume is unmuted on the device you're watching from. Locate the volume control and increase or reduce the volume as needed. YouTube offers a closed caption option by clicking subtitles from the settings or gear icon. For video, you can pause and rewind during the live broadcast and resume where you left off, or click live to reconnect to the live stream of the presentation. You may enlarge the webinar broadcast screen by clicking the full screen icon located in the bottom right-hand corner. This webinar is being recorded and can be viewed on our website and YouTube channel shortly after this broadcast. When watching a previously recorded broadcast, please note you're able to adjust the playback speed incrementally slower or faster by clicking playback speed from the settings icon. Our YouTube channel features 500 educational videos, testimonials, and podcasts. Click videos or playlists to find information on types of treatments such as PRRT, liver-directed and targeted systemic therapies. You'll find information on imaging, surgery, and our annual conferences and patient and caregiver stories. You can also find our educational videos by topic on our website's video library under the Resources tab. Find us on social media, Facebook, X, and Instagram with the handle @NCFCancer. And be sure to add us to your Safe Sender email list. I'd like to remind our audience that our webinars are created for educational purposes only and do not substitute for medical advice. The views shared in this webinar are from the experts' experience and insights. Please contact your medical team with questions or concerns about your individual care or treatment. And now I'll hand it over to Lisa.
I'm pleased to introduce today's speaker, Dr. Aman Chauhan, a medical oncologist and nationally recognized neuroendocrine cancer expert. He currently leads the University of Miami Neuroendocrine Cancer Program and co-leads the Sylvester Theranostics Drug Development Program. He will soon be moving to San Francisco and joining the UC San Francisco Neuroendocrine Cancer team in January 2026. Dr. Chauhan completed his medical training in India, followed by a dual residency in internal medicine and pediatrics at LSU in New Orleans, and a hematology-oncology fellowship at the University of Kentucky with a special focus on neuroendocrine cancer. He also completed a physician externship at the National Cancer Institute in Bethesda, Maryland, where he trained in clinical trial design. Clinically, Dr. Chauhan exclusively treats neuroendocrine cancer, including lung and high grade, And in research, he serves as principal investigator on multiple neuroendocrine cancer clinical trials, and he has authored more than 70 publications. He serves on both the ASCO, ASCO, and AJCC NET guideline committees, and most recently, Dr. Chauhan was elected to the board of NANETS, the Medical and Scientific Community for Neuroendocrine Cancer. Many of you know Dr. Chauhan for his deep commitment to patient care. Today, he's here to help demystify immunotherapy in both neuroendocrine tumors and neuroendocrine carcinomas. Welcome, Dr. Chauhan.
Hello, everybody. My name is Aman Chauhan. I'm a medical oncologist. I lead our neuroendocrine cancer program at University of Miami, and I also co-direct our theranostics program at Sylvester Comprehensive Cancer Center. Today, we have a very exciting topic we'll be discussing, and that's role of immunotherapy in management of neuroendocrine cancer. Before I go further, I first like to lay out the landscape of neuroendocrine oncology. Neuroendocrine cancers are not one single disease entity, rather a spectrum of diseases. We can categorize them essentially into two main categories based on how they look under the microscope, into well-differentiated neuroendocrine tumor or poorly differentiated neuroendocrine carcinoma, NET or NEC. And why it's important for us to understand that these two different distinct categories exist is because they are different diseases with different outcomes. As you can see here, these are the Kaplan-Meier curves for disease-specific survival. The line on the top has the best outcome, and these are well-differentiated NET, low-grade to intermediate-grade tumor, as compared to higher-grade well-differentiated neuroendocrine tumor in the blue line, as compared to the poorly differentiated neuroendocrine carcinoma on the red line. It is very important for us to understand what disease we are discussing and dealing with, and the outcome of the treatments, be it chemotherapy, immunotherapy, also varies based on the disease. So, in the beginning, we will first discuss role of immunotherapy in well-differentiated neuroendocrine tumor, which are further of grade 1, 2, and 3 varieties. But the initial segment of the talk will focus on NETs, and then we will touch up on NECs. So, currently, immunotherapy is not routinely used in well-differentiated neuroendocrine tumor. It's very unfortunate, but that's the reality. Barring a small caveat, there used to be an old drug called interferon alpha, which does have some immunomodulatory effects. So it does activate our immune system to help fight the cancer. But because of its significant side effects, the cumbersome nature of how to administer it, and very limited response rate and effectiveness, the use is basically antiquated and is very limited role in the current scheme of things for interferon alpha. So essentially, no conventional immunotherapy drugs are used in management of well-differentiated neuroendocrine tumors. These are the recent advances that we have seen in the world of neuroendocrine oncology for well-differentiated NETs. As you can see here, we see chemotherapy, we see role of somatostatin analogs, targeted therapy with everolimus, sunitinib, and chemotherapy with CAPE-HEM, PRRT, theranostics with lutetium 177 dotatate, and the most recent entrant, cabozantinib with VEGF TKIs. But there is a stark omission. There's no immunotherapy drugs here. And it is very unfortunate, and it's not for lack of trying. There has been several clinical trials that has investigated immune checkpoint inhibitors or the conventional immunotherapy drugs that are hugely popular in other oncology world with melanoma, kidney cancer, lung cancer, but has not been very successful when it comes to neuroendocrine tumors. I just put forth a small list of clinical trials that included neuroendocrine tumor patients in some form, either as a part of the basket cohort or pan-tumor type phase 1 studies. And as you can see, essentially most of these studies were negative or had very limited effectiveness in well-differentiated neuroendocrine tumor. And why that may be, well, don't fully understand, but there are some hypotheses. This is a landmark paper that was published in Nature, And in this paper, the investigator studied all different type of cancers and the somatic mutation burden or the frequency seen in different cancers. And as you can see here, the carcinoid, the well-differentiated low-grade neuroendocrine tumors, they often tend to have a lower somatic mutation burden. And over the years, what we have realized is the cancers which tend to have higher mutation burden also seem to benefit from immune checkpoint inhibitors. On the right hand of the screen, you'll see lung cancer, melanoma. These are classic areas of oncology where immune checkpoint inhibitors have made huge advances and has a big role to play. So this is probably part of the puzzle, but not the complete picture. We still need to understand why some NET patients, anecdotal cases, they respond beautifully while majority don't, and what can we do to switch that? So moving forward, when we discuss immunotherapy, what do we mean by immunotherapy? The general definition is any drug that utilizes our own immune system to fight the cancer is a form of immunotherapy. Immune checkpoint inhibitors are one of them. We will touch up on that in a bit. Cancer vaccines is another form of immunotherapy. Oncolytic viruses, where we infect a tumor with a virus that destroys the tumor and then elicits an immune response to build on that inflammation, is also a type of immunotherapy. And then T cell engagers. These are the drugs that engage our T cells or the fighter immune cells and forces them to kill cancer cells, are also the newest form of immunotherapy that we are currently using. Not all of these immunotherapy drugs are currently being developed in neuroendocrine world, but I will touch upon some of those which are showing some promise. And we will start off with CAR T therapies. Now, CAR T are basically a technology that is revolutionizing oncology and have found cures in certain leukemias and lymphomas. So what is it? In simple term, it is basically re-engineering our T cells to fight against the cancer cells. And we try to engineer them in a way that they attack a particular antigen that is just seen in the cancer cell and not the normal body cells. So these T cells are first extracted from the patient, and then they're engineered, bioengineered, and then they're infused back into the patient, where then they target specifically the cancers with those antigens. So the first one among the CAR T therapies that sounds very promising and is focusing on neuroendocrine cancer patients is a study, a multi-center phase 1 study by Chimeric Therapeutics. UPenn is taking a lead with Dr. Jennifer Eads, the PI on the study, and they are testing a drug that targets cadherin 17 through CAR T. Well, cadherin 17, CDH17 is expressed in normal tissue as well. However, it is hidden, as you can see in those between the tight cell junctions. So if you develop this CAR T cells that attacks the CDH17, it won't attack the normal tissue. However, on neuroendocrine tumor cells, what the investigators have found that CDH17 is expressed quite abundantly, making them a very good target for these CAR Ts to go and attack the tumor cells without affecting normal body. So that's the rationale for using this. So this is a phase 1/2 open label study. That means all the patients who meet the eligibility criteria will get the active drug. They are currently looking at what is the safe dose and what are the side effects, etc. So it's very early. It's a multi-center study. All the eligible patients will undergo leukapheresis. This is a process where the investigators would collect their blood cells and then enrich them. And the modified cells will then be infused back to the patient, which hopefully will then attack the CDH17 positive cancer cells. So very cool technology, and wishing all the best to the investigators. I think this could be a big breakthrough. in the near future. Another study in the similar lines, utilizing CAR-T technology, is coming from Dr. Anusha Kalbasi's group. Again, another multi-center study, first started at UCLA, and now including Stanford and part of this phase one. They are developing a CAR-T therapy that targets IL-13R alpha 2. Initially, this target was investigated in melanomas, but now the investigators are also looking at other solid tumors, including neuroendocrine tumors. They found that this particular target may be expressed in neuroendocrine tumors and neuroendocrine carcinomas. So its study is currently enrolling. Patients can participate. They can send their tissue to screen for this particular target, and if they are eligible, they might be able to participate in this particular CAR-T therapy. So again, very, very exciting times for neuroendocrine oncology, where we are seeing interest from our CAR-T enthusiasts and supporting our patients in developing novel therapies in this area. Let's move on to another very exciting area of immunotherapy and neuroendocrine cancers, and that's cancer vaccines. We probably heard a lot about cancer vaccines. So there are not a whole lot of cancer vaccine trials that are catering to neuroendocrine tumor patient population. But thanks to Dr. Renuka Iyer, one of the seasoned neuroendocrine tumor specialists from Roswell Park, is leading one of a novel cancer vaccine trials catering to patients. So what is this trial? Well, the vaccine they're testing, called Survax M, it's a 15 amino acid peptide vaccine. It stimulates the antigen presentation via intercellular cell surface target recognition and induce the immune response utilizing our fighter cells, the CD8s. It is currently in the phase one. That means the investigators are trying to look for the safety profile of the vaccine, the maximum tolerated doses, and also looking at the efficacy pattern. So very, very excited about these developments. This is the study schema. As you can see, in the early phase of the study, patients are getting these vaccines every 2 weeks for up to 4 doses. And those patients who tolerate it well and are benefiting from it, they continue to get these vaccines every 12 weeks for up to 1 year. Again, these novel immunotherapies hold a lot of promise. And if we do see success here, hopefully this will progress to randomized phase two and phase three in the future. So thanks to our colleagues, wonderful Dr. Iyer and colleagues from Roswell Park for spearheading this clinical trials and testing out cancer vaccines for neuroendocrine cancer patients. We will switch gears now and discuss some novel developments regarding immunotherapy for high-grade or poorly differentiated neuroendocrine cancers. NECs, or poorly differentiated neuroendocrine cancers, can be of further two subtypes, small cell and large cell, based on how they look under the microscope. And one of the commonest high-grade neuroendocrine cancers is called small cell lung cancer. It represents almost 14 to 17% of all lung cancers. So it's pretty common. And it's also a very aggressive cancer with median survival in 1.5 to 2 year range, 5-year survival under 15%. And for the longest time, we used to treat small cell lung cancer and other high-grade neuroendocrine cancer with chemotherapy, which has high toxicity and limited efficacy. However, all that changed a few years back with invent of immune checkpoint inhibitors. On the right-hand side, you see two Nobel laureates who received the Nobel Prize for their role in uncovering immune checkpoints and helping us develop therapies that will lead to immune checkpoint inhibitors. So what are immune checkpoint and immune checkpoint inhibitors? Like cancer cells on left side of your slide, they express this protein called PD-L1. And just like bacteria, viruses, cancer cells are supposed to be foreign to our body. If I develop a tumor in my body, I expect my immune system to recognize it and attack it. However, that does not happen just the way a bacteria or the virus will get cleared up by immune system. Why does cancer cells survive? These investigators found one of the reasons why the cancer cell are able to evade our immune system is because they are invisible to our immune system. When I say immune system, these are T cells, these are the fighter immune system cells that recognize the cancer or foreign bodies and then attack them. So these PDL1 protein, think of them like an invisibility cloak. When the cancer cell is wearing it, it becomes invisible to our immune system. When these scientists recognize that this is happening, it was easy to then uncloak the cancer cell by developing a drug that neutralizes these PDL1s. So that's why the name PDL1 inhibitor or immune checkpoint inhibitor. These PDL1 is a type of checkpoint protein. So if you develop an inhibitor or an antidote to it, it will help the immune cell to again make cancer cell visible to it and attack it. And this class of drug has been hugely successful in oncology. And I can't think of any major cancer that currently, where we don't have role of immune checkpoint inhibitor. It's starting from melanoma, kidney cancer, lung cancer, bladder cancer, you name it. Many cancers currently use immune checkpoint inhibitor for treatment of neuroendocrine cancer. However, in high-grade neuroendocrine cancers, it's still under investigation. Small cell lung cancer is an exception. And for the longest time, since 1970, small cell lung cancer, we were used to treat it with chemotherapy with carboplatin etoposide. The first advance happened with IM Power 133 clinical trial, where the patient either received the standard of care carboplatin etoposide and other half received carboplatin etoposide, plus this immune checkpoint inhibitor that I was talking about called atezolizumab. And this study showed that patients who received immunotherapy in addition to chemotherapy, they did better, they lived longer. And this study led to FDA approval of immune checkpoint inhibitor for high-grade neuroendocrine cancer, specifically small cell lung cancer. So this was a good first step. And subsequently, other immune checkpoint inhibitors were tested and were also approved, for example, durvalumab in small cell lung cancer. Now, the question is, would it work for other NEC or high-grade neuroendocrine cancer outside small cell lung cancer? Well, our colleagues are trying to figure that out for us. Dr. Zen and Dr. Chirin from SWOG are leading this large national multi-center clinical trial. It's a cooperative group study, that means federally funded, and they are testing addition of atezolizumab to the standard chemotherapy versus standard chemotherapy. And this trial is currently enrolling very well and is looking at high-grade NEC patients outside lung, including prostate, GI tract, etc. So if this study turns out to be positive, like small cell lung cancer, it might lead to incorporation of immune checkpoint inhibitor in the management of NEC. Moving forward, there have been other exciting developments in small cell lung cancer space, especially with regarding to a novel type of immunotherapy drug called DLL3 targeted bispecific T cell engager or BiTE. We have our first FDA approval in the drug named tarlatamab with very impressive response rates. That means 40% patients showed disease shrinkage, almost 70% patients showed clinical benefit using this drug in extensive stage small cell lung cancer. And the patients who had progressed on standard chemotherapy, the platinum-based frontline chemotherapy. So these are extremely exciting results, and we now have a very effective tool to fight small cell lung cancer with the help of this novel immunotherapy. So what is this DLL3 T cell engager, and why such optimism in high-grade neuroendocrine space regarding this class of drug? Well, before I go into what DLL3 is, this is my own experience. These are early days with tarlatamab, and I was part of a phase 1 study This is several years back, and I had a patient who had progressed through 5 or 6 lines of therapy and came to me in search for a clinical trial for small cell lung cancer. And we tried tarlatamab in combination with checkpoint inhibitor. And 2 years later, this patient was in near complete response and doing pretty good. Now, those are the kind of responses we don't see with conventional chemotherapy, those deep, durable responses. And I knew early on that there was something very exciting, promising about DLL3 T cell engager therapies. Fast forward to now, it's already FDA approved. So let's learn a little bit about DLL3, what it is, and how do we target it. Well, DLL3 is a notch ligand, which is expressed on surface of small cell lung cancer and all other high-grade neuroendocrine cancers, including the extrapulmonary neuroendocrine carcinomas. So this is a protein that is expressed on high-grade neuroendocrine cancers. What if we have a drug here? You see a drug that has binding affinity to DLL3, binds to DLL3, and the other end of the drug binds to the immune cells. Wouldn't it be so cool? Well, we do have that drug. So when we inject this DLL3 T cell engager, it goes into the blood and tries to find and latches onto the cancer cells, which has DLL3. And with the other arm, it latches onto the T cells, which are our own immune cells, so the patient's own immune cells. And when it's able to successfully latch to the cancer cell and the T cell, it forces them to come closer. This causes the activation of T cells. And the T cell's job is to kill the cancer cells, cause an inflammation. This cytolytic synapse, that means this inflammation would eventually lead to cancer being killed and cleaned up. So this is what the DLL3 T cell engagers, as the name says, it engages the T cells to the DLL3 positive cancer cells. So very, very cool concept. And currently we have not one, but several clinical trials, several drugs that are investigating this class of drug. And the reason why there is so much optimism about developing DLL3 T cell engager in high-grade neuroendocrine cancer is because we are not looking at needle in the haystack. DLL3 is expressed in vast majority of these patients. As you can see here, almost 80% patients with small cell lung cancer have DLL3, and similar trends are being seen in high-grade neuroendocrine cancer, be it large cell neuroendocrine cancer or small cell carcinoma outside lung. And again, 75 to 80% patients do express this target. So it has potential to benefit vast majority of patients and not minority subgroup. As I mentioned before, we have drugs like tarlatamab. We have other very, very important drugs in the similar spectrum being developed by Harpoon Therapeutics, Roche. But I'd like to give a special shout out to Boehringer Ingelheim. This is a company based out of Europe who are specifically investigating DLL3 bispecific T cell engager called obrextimab in high-grade neuroendocrine cancers outside lung. So not only they are investigating lung, but they are also hyper-focused in helping us develop therapy for poorly differentiated neuroendocrine cancers outside lung, which in my mind is a critical unmet need, and we don't have good therapies for these patients. So they initially did a phase 1 study where they treated small cell lung cancer patients, high-grade neuroendocrine carcinoma outside lung patients, and large cell neuroendocrine carcinoma patients to see safety of the drug, to find the recommended phase 2 dose, and also get some efficacy signals. And the early data, and you can find these data from various meetings, last year ASCO, ESMO, this year's ESMO, NANETS. As the data continues to evolve and mature, BI has been pushing the data out for everybody to see. And as expected, what we are seeing here is patients who have high DLL3 expression, they tend to show more effectiveness, more disease shrinkage. So almost 40% response rate in high DLL3 expressors. What is even more gratifying than response rate is the durability of response. These are the swimmer's plots, and you can see here patients who have high DLL3, they tend to respond for a longer duration. Some of these patients are on these drugs for several months, as you can see on the x-axis. This is the months on the duration of treatment. You just don't see that with conventional chemotherapy, this deep, durable responses. And that's where the promise of immunotherapy lies. The patients who respond, they tend to respond for a much longer period of time as compared to conventional chemotherapies. Earlier in November, I presented data from the similar series of studies called Darien set of studies. Darien 5 is testing obrextimig in refractory neuroendocrine cancer patients. When there is a drug that is effective, the next thought is to bring that drug up front and combine it with drugs that are already effective to make them even better. And this is where the Darien 7 genesis took place. So obrextimib was tested in the frontline setting, a newly diagnosed patient with extrapulmonary neuroendocrine carcinoma, and combining to frontline chemotherapy. And I had the opportunity to present these data at NANETS in Austin this year. And I'll just show you a quick snippet of the key findings. As you can see, we found the combination of obrextimig, this DLL3 bispecific T-cell engager, with conventional chemotherapy with carboplatin etoposide to be very safe. We did not see any heightened toxicity. Moreover, we saw exceptional response rates with the combination. As you can see here, these are the waterfall plots. Majority of the patients had partial response, and these data are still quite early, and we would like to continue to follow these patients to see the durability of the response, how long these responses last. But these are some very, very exciting and promising early findings. And I'm hoping that this phase 1 will eventually lead to a randomized phase 3 at some point in the near future. All right, so this is where the promise of DLL3 lies in very exciting times. We already have a DLL3 T-cell engager in tarlatamab FDA approved for small cell lung cancer. And the Darien series of studies are investigating it very hard and fast in extrapulmonary neuroendocrine cancer space. And I wish them all the best because therapies are badly needed for extrapulmonary neuroendocrine cancers. Now, besides the DLL3 targeting T-cell engager, is there any other tool in our toolbox that we can investigate for high-grade neuroendocrine cancer? My personal efforts for past 5 to 7 years been looking into an oncolytic virus-based therapy in high-grade neuroendocrine cancers, and we've collaborated with Seneca Therapeutics. You can see the co-founder of Seneca Therapeutics, Paul, who discovered Seneca Valley virus and also found that it has anti-cancer properties. And I had the privilege to write this study and develop it as an investigator-initiated phase 1 study currently enrolling at University of Miami. So let's discuss a little bit about what it is. The Seneca Valley virus is an oncolytic picornavirus. This means this virus infects cancer cells. It does not hurt the normal host or normal human cells. And that's the beauty of these oncolytic viruses. There are several oncolytic viruses currently in the development. And this particular virus was found to be very effective in killing high-grade neuroendocrine cancers. Dr. Charlie Rudin from Memorial Sloan Kettering did a lot of early work in small cell lung cancer using this drug and had some very good responses from animal models. They later tested this drug in some neuroendocrine tumor patients and a lot of small cell lung cancer patients. Unfortunately, while this drug was found to be very safe, it was not found to be very effective in small cell lung cancer. And over the years, figured out what the issue was. One, the drug that was tested back in the day was administered through IV. And the problem with IV administration is your immune system clears the oncolytic virus pretty early. So most of the current drug development in oncolytic virus space is happening with help of intratumoral injection, where we actually inject the virus into the tumor that gives them a little bit better shot at surviving the immune system and grow and thrive in the cancer cell so that it can kill the cancer cell. Moreover, over the years, we have learned that there's actually a receptor for Seneca Valley virus, and it's called TEM8. So we have now technology to screen for TEM8, and we now understand that Seneca Valley virus is very effective if the cancer cells expresses TEM8. Again, all of these needs to be confirmed in human studies, which we are currently doing. And last but not the least, we are also observing that these oncolytic virus therapies do exceptionally well when you combine it with the conventional immune checkpoint inhibitor therapies. And this is being now noticed across the spectrum in different cancer types, including different oncolytic viruses as well. We wanted to test that hypothesis. Now, the conventional immune checkpoint inhibitors like ipilimumab or nivolumab, they oftentimes don't work in majority of patients, unfortunately. But those few patients where it works like a charm. Again, this is a patient of mine with poorly differentiated neuroendocrine carcinoma on the immune checkpoint inhibitor doublet with ipilimumab, nivolumab, with near complete response and great outcome. I wish these outcomes were common and not anecdotal. However, we are hoping to change that with this oncolytic virus therapy concept. This is a list of clinical trials using conventional immune checkpoint inhibitors, except for SWOG DAR 1609. All the studies have been not very impressive using immune checkpoint inhibitors in high-grade neuroendocrine cancers. But there is a promise that we see from SWOG DART 1609, where in this very small study, they did find a group of patients who had a very good benefit from ipi-nivo in high-grade neuroendocrine cancers. So we want to build on the success of SWOG DART and combine something to ipi-nivo to make these drugs even effective. So we combined the ipi-nivo with Seneca Valley virus, and these are some of the examples from our preclinical studies from animal models. And as you can see, the mice with the tumors, they had the best cure rates when you added Seneca Valley virus to anti-PD-1, anti-CTLA-4 based therapies. Very, very impressive results. But now the true test would be whether it translates into humans. And currently we are doing this first in human phase 1 clinical trial of combination ipilimumab, nivolumab with Seneca Valley virus in all high-grade neuroendocrine cancer patients, be it well-differentiated grade 3 or poorly differentiated grade of poorly differentiated neuroendocrine carcinomas. And we are also looking for TEM8 expression, viral kinetics, etc. This is the study schema, and you're probably the first one to hear, as this just happened earlier this week. We are now halfway done, and the part A, that is the single dose cohort for Seneca Valley virus, where we just inject patient one time into the tumor, and then patient then receives standard of care nivo systemically. That single dose cohort is completed, and we have treated patients in dose level 1, 2, and 3 with single dose cohorts. January 2026 onwards, we look forward to opening part B, where we will inject a patient with multiple doses of Seneca Valley virus as long as they are able to tolerate it and they are seeing benefit from it. So very, very exciting developments and trials enrolling very well. And we are also hopeful to open this clinical trial beyond University of Miami and expanding into UCSF in near future. With that, I would like to thank all the audience for tuning in today. I clearly could not cover all the things that are happening in immunotherapy space. However, I wanted to touch upon some of the key new developments where patients can actually participate. These are not just concepts, these are actual clinical trials currently enrolling from different subtypes of immunotherapies, be it CAR T, be it vaccines or oncolytic virus or combination form of immune checkpoint inhibitors. So very exciting times. We haven't yet given up on immunotherapy, and I'm still a big believer of immunotherapy. I believe if one fine day cure will come, it will come through one of the types of immunotherapy drugs. With that, I'd like to thank you for your attention and happy to address any questions.
To have this overview on immunotherapy as so much has changed over these years. And thank you for this very informative talk. So just a reminder to our audience, this question and answer session is for educational purposes only, and it does not substitute for medical advice. We encourage you to talk to your medical team with questions or concerns about individual care or treatment. We did receive over 35 questions and they're still trickling in. So we will try to get to as many general questions on this topic of immunotherapy as possible. But please note that we will address broad-based questions only on this topic. And Dr. Chauhan does not provide specific feedback on your specific situation. Also, we will not necessarily address the questions in the order they were submitted, but instead an order that makes sense. So Dr. Chauhan, thank you again for being here in the middle of your transition to San Francisco. It's great to have you.
Thank you, Lisa, and thank you to the team of Neuroendocrine Cancer Foundation. First of all, hats off for organizing a talk on such a unique topic. We don't really talk much about immunotherapy when it comes to neuroendocrine cancers. So thank you for spotlighting the advances in immunotherapy. And I know a lot of patients have questions regarding this, and 30 questions already. Wow. Uh, Looking forward to our discussion.
Yeah, it looks like we're up to 38 questions. And even though it may not be something that gets spotlighted often, it comes up at nearly every conference, at every meeting in person and virtual that we have. So I'm glad that we have this space to talk about it. So let's get to the questions, shall we?
Absolutely.
Okay.
Let's do it.
So with that, I'm going to start first with a CAR T because this is, as you highlighted, it's something that comes up in the news for other cancers. I know you kind of touch on a couple of the trials. So what is the status of the CAR T trials now? I think a lot of people are wondering specifically if there's any information or data that's come out.
So CAR T trials, just in general for oncology, be it solid tumors or blood cancers, leukemias, lymphomas, is now one of the mainstream treatments. Uh, and there's a lot of research happening in this particular space. Now, with regards specifically to rarer cancers, especially neuroendocrine cancer, these are still very early days for CAR T therapies. There are two clinical trials that I spotlighted. One which is happening currently at University of Pennsylvania and few other associated centers, and is studying CAR T therapy specifically in neuroendocrine cancer patients, be it both low grade as well as high grade neuroendocrine cancers. So that would be a good study to consider. It's first in human phase 1 study. That means right now the investigators are mainly focused on the safety, if this technology can be safely implemented in humans. And then, of course, we are also looking for hints of efficacy, that how effective is this therapy? Are we seeing patients benefiting from this therapy? But these are still very early days. The second CAR T therapy that I highlighted is, was started by UCLA, and now Stanford and few other centers in the West Coast are participating. That CAR-T technology first was investigated in melanomas and other cancers, but I'm glad that the investigators also thought to include neuroendocrine cancers because the target apparently is also expressed in some neuroendocrine cancer patients. So they are currently welcoming patients for getting screened to see if they may qualify or may benefit from this particular therapies. To my knowledge, these are two most exciting and promising CAR T therapies in neuroendocrine cancer space, but that doesn't mean that others are not being thought of or in development. A few months back, I met with some of my colleagues at one of the meetings in Bermuda, And I spoke to some investigators in Europe who are trying to develop CAR T therapy directed towards DLL3. Similarly, there are other investigators trying to develop CAR T therapy towards somatostatin receptors. And you've heard a lot about these targets. These are very common targets in our space. But right now, these concepts are at lab. They are not at a stage where we have a drug that we can actually administer to humans. So I will keep you posted. I will be that communicator. So next time we talk, Lisa, maybe we have more news in this front.
Yeah, that's helpful. So there's a wide range of CAR T, even when you're talking about it. It's not one size fits all, even within that space. There was a question that comes up specifically about CAR T. If what, if anything, do you know about the CAR NK?
Right. So these are two wonderful cellular therapies or the type of immunotherapies where we inject the actual immune cell that fights against the cancer. Now, CAR T is unique in the sense where we first take those immune cells from the patient, we bioengineer them, then we make multiple copies of them, and then we put them back into the patient. Because after that bioengineering, we have made them specifically target the cancer cells. So that's basically, in a sense, what CAR T therapy is doing. NK therapy, in contrast, may be bioengineered or may not. So that's why in NK therapies, you most of the time don't really need to pull these NK cells from the patients. They're ready off the shelf because natural killer cells, we all have them, and they're not target specific. They will attack anything that is abnormal or foreign to the body, be it a infectious agent, foreign body, or a tumor. So they don't really need to be engineered. My NK cells or somebody else's NK cells, they are engineered they are naturally, designed in a way by nature to attack anything that is not supposed to be there. So that's the slight advantage of NK cell technology. So they can be used off the shelf and be readily deployed and administered to the patient. The flip side is what I've been reading from my research. The benefit are not as long lasting as CAR T cells. So again, these are two good techniques and technologies. I think there's a role for both of them right now. I'm looking forward to see how they pan out in neuroendocrine cancer, but slightly similar and somewhat different.
Yes, thank you for that. There's a lot of excitement, as you mentioned, around DL3. So I guess this is the most upvoted question. How does one go about getting their cancer profile for targeted biomarkers like DL3? And is there an off-the-shelf test available?
Great question. And I have some good news. About maybe 2 years back, this testing was not readily available outside research testing. So if patient part of any clinical trial, then the research teams have their own in-house test to do DLL3 testing. As of now, there are a few commercial labs that are offering this DLL3 testing. It's a rather straightforward test. It's called immunohistochemistry test, where patients' slides or the tumor slides are sent and are stained with the DLL3 antibodies and see if they are positive or not. In fact, many hospitals, including ours at the University of Miami, we are doing it in-house. Our own pathology department has this technology. It's not a very sophisticated technology, and many cancer centers are now also offering it in-house. So you can ask your oncologist, third-party commercial labs like Mayo Clinic labs have been offering it for a long time, but several others have now entered, and including your own hospital might do it. You don't might not even have to send it out for testing. So it's becoming more available. The bigger question is, what do we do with that information? Because right now, it's not as if we test somebody for a DLL3 and if it's positive that we have a therapy to offer. All the treatments that are currently in the offing are as a part of clinical trial. And in small cell lung cancer space, where tarlatamab, the DLL3 BiTE antibody, which is already FDA approved, DLL3 testing is not even needed. So that leads to the question, what's the current utility of doing DLL3 testing outside of research? I think you will hear more about it in near future as we are trying to understand the role of DLL3 biomarker, if high versus low matters, etc. But at least the test is available for those who are interested.
Thank you. And that was actually a follow-up question. Is there a certain amount of DLL3 protein that the tumor needs to express to qualify for DLL3 treatment?
Great question again. And to be honest, we might not fully know it entirely. As you know, there are several drugs in the development that targets DLL3. Obrixtamig is one of them, and there is another from Harpoon Therapeutics, and Amgen drug tarlatamab is already FDA approved. However, in Obrixtamig clinical trial, we had an opportunity, the Darien-5 clinical trial, to study patients who had high DLL3 versus low DLL3. And it seems, as of today, that patients who have high DLL3 expression tend to benefit more. Again, these are trials that are still ongoing. It's not a concluded trial, and it's not a final verdict on this. But the early data, which is already in public domain and was presented in several meetings earlier this year, alludes to the fact that high DLL3 corresponds to some benefit, especially in extrathoracic high-grade neuroendocrine cancer. So not small cell lung cancer, not lung cancers, but these are neuroendocrine cancers or carcinomas outside lung. It seems, at least in the Darien studies, high DLL3 corresponds to better response. But I don't want to dissuade people who don't have high DLL3 expression from not participating in these trials. If the trials are accepting patients who are agnostic of DLL3, I think this is still a very good treatment to be considered, because we truly don't know. There could be patients who are just 10% expressor or 5% and may still show good response. So again, not to be taken at face value for the time being.
Yeah, still a work in progress. And could you define what you mean by high DLL3 or what the trials meant?
You hit the nail on the head. And this is one of the conundrums. We don't know. So arbitrarily in the Darien study, we have picked DLL3 of 50%. So more than 50% tumors positive for DLL3 are high expressors or low expressors. But another drug for another compound may have different sensitivities, or maybe just 25% is high enough. So again, these are things that are yet to be teased out in different trials and different studies. But for the timing, the data that was presented, it seems the DLL3 cutoff was made to be 50%. So more than 50% were considered high expressors versus low expressors. Again, this is the first stab at the data. And I think finer nuance and refinement needs to be done as we treat more patients and understand the importance of this biomarker and how it correlates with the response rates and the durability or the longevity of responses.
Right, right. Okay, so still yet to be defined, but at least in the recent study, it was defined as greater than 50%. Okay, so a somewhat related question. What's the efficacy threshold for DLL3? And I know this is still a work in progress, but if one's DLL3 was, say, 10 times the minimal level for efficacy, does that predict a better response? And is there a better chance of shrinkage or even no evidence of disease?
Yes, at this point, the best data that we have, which again, to be taken with a grain of salt for now, is 50% expression. So extrathoracic, that means neuroendocrine cancer patients outside lung in the Darien group of studies, those who had high expression of DLL3 more than 50%, they definitely did better than the ones who had lower expression. And this is new information. Last year or a year before that, when we were treating patients, we did not have this knowledge. So we were treating everybody. So Darien 5 clinical trial right now that is reopened for enrollment at several sites in the US and outside US is screening patients for high DLL3 because we are seeing a trend favoring towards high DLL3 as the responders. But that's it. Does that threshold also carry forward to the tarlatamab drug or the other drugs in this space? We can't say that, because although these drugs have similar mechanism of action, they are very unique drugs, and they may have their own binding affinity, clearance, and pharmacokinetics. So maybe 10% is more all we need for certain drugs, or maybe some drugs need even higher expression. So again, this is just for one drug for one particular study.
Yeah, yeah. Well, it's hopeful that there are multiple studies going on. So for the people who are fortunate to get the DL3 and for the cancer to be cleared or have no evidence of disease, will that person need immunotherapy for life?
That's a great question, and that would be a good problem to have, to be honest. In a disease type like high-grade neuroendocrine cancer, where unfortunately the 5-year survival rates are nowhere close to where we want them to be. So if a patient has a great response to DLL3 therapy and continues to be on drug, uh, we don't know what is the upper limit of the threshold. In past, patients who have had complete response or had a really good response for over 2 years, they have cautiously decided to stop the therapy and continue monitoring. Um, and some patients have decided to continue therapy till progression or side effects. These are uncharted territories. If I have a patient who is benefiting from this novel immunotherapy and it's been on it for 2, 3 years, I would say keep on, because I don't want to rock the boat when it's giving us results. But in future, once these technologies have been in the market and patients being treated for 5, 7, 8 years, we'll have more real world data that do we really need, and patients who are responding beyond 5 years or beyond 4 years, maybe the cancer is all gone by then, so those are all theoretical possibilities. But for the time being, we keep them as long as patients benefiting, as long as they're not having side effects and they see utility in continuing treatments. Again, there are burdens associated with treatment,
Yeah.
the monthly infusions or every 2 weekly infusions, etc.
Yes. So we hope to have that problem and to be able to find answers, real world data around that. Thank you for all who are participating in these trials to help us learn more about this. And somewhat related, but not also, does every person who receives immunotherapy have to be tested for DLL3? And then what if they don't have this marker?
Great question. Um, so DLL3 is only needed for DLL3 specific immunotherapy, which are T cell engager based therapies, right? When we talk of immunotherapy, there are immune checkpoint inhibitors that targets PD-1, PD-L1, so completely different mechanism targets. Oncolytic virus therapy is targeting something different. Cancer vaccine is targeting something different, and CAR Ts are targeting very CAR T specific receptor. So DLM3 for the timing is being developed within the immunotherapy realm with the T cell engager based treatments. So for that particular, I think DLL3 screening is happening in several trials, but not all trials. There are some early phase clinical trials, or maybe some early phase clinical trials that are welcoming all NEC patients regardless of their DLL3 status. But at least the Darien series of studies, they are at a stage where they have the phase 1 data and they're maturing to the phase 2, and they are refining it to more DLL3 high expressor for Darien 5. There are other Darien studies which are, for example, the Darien 7, where they're combining the DLL3 BiTE therapy with chemotherapy, and I don't think there is any such threshold requirement. It needs to be positive, I fear, but there might not be a threshold requirement for high DLL3 expression or not. Again, these are the things you need to discuss with the investigators, because there are changes in the protocols all the time and refinements, and things may change over a period of time. So some trials may still not need the DLL3 expression as long as you have the disease type. Some the classic example is small cell lung cancer trials, where DLL3 expression is not needed. Patients, if you have small cell lung cancer, you can get the DLL3 by therapies, and there are several trials in the front line and the second line targeting that technology.
Thank you. So kind of revisiting what the science is behind this, people want to understand, right? What is the function of the DL3 receptor again? I know you kind of touched on this, but people are aware of the somatostatin receptors. Does DL3 bind to somatostatin that somatostatin, what does DL3 bind to?
Yes, a great question. Very distinct, have no correlation with each other. Somatostatin receptor is one of the proteins that is heavily prevalent in neuroendocrine tumor, especially the low-grade, well-differentiated neuroendocrine tumor, not so much in high-grade, poorly differentiated neuroendocrine carcinoma. That's why we are not really seeing a lot of somatostatin receptor target therapy in poorly differentiated neuroendocrine cancers. So we needed another target, another target that is abundant in high-grade neuroendocrine cancer, and we stumbled upon DLL3. DLL3 is another protein. It's a family of Notch pathway receptor protein, which is activated in high-grade neuroendocrine cancer. So there's DLL1, 2, 3, 4, and 5. DLL3 is very common and is expressed in more than 75 to 80% high-grade neuroendocrine cancer patients, regardless of lung or outside lung. So the first litmus test for any target is that needs to be present in majority of patients to make it very good, attractive target for drug development. Imagine if we have a target that is only seen in 2% of patients, not very attractive, especially in rare cancer. So DLL3 is a protein that is seen in high-grade neuroendocrine cancer. This protein is resulted as a result of activation of a cancer pathway called Notch pathway that is implicated in the tumor cell growth. It's one of the canonical pathways why this cancer become the way it is behaving. And so that activation of pathway leads to expression of this protein in abundance in high-grade neuroendocrine cancer. And we are using this property of high-grade neuroendocrine cancer to now target DLL3 positive tumors. And the first of the lot is the T cell engagers, but we are not stopping there. You will see in future that there will be DLL3 targeted radiopharmaceutical trials that are like PRRT drugs that target DLL3. There are DLL3 targeting ADCs. These are smart chemotherapies that will target DLL3 on the cancer cells. So DLL3 is just a target which is heavily expressed, and you will see different types of drugs that will be developed to target DLL3 positive cancers.
Thank you for clarifying. Yeah, so there's a wide range out there. This is just the beginning. And speaking of somatostatin receptors, could immunotherapy replace treatment with lanreotide?
I don't think so. They're very distinct. Lanreotide has been in the picture for several years, in fact, few decades now, and works really well. Unfortunately, like most of the cancer drugs that we have for well-defined neuroendocrine tumor are not curative. So lanreotide, although it's great and controls the disease for a long period of time and has a very good side effect profile, but cannot cure it. So this is where immunotherapy differentiates us from other cancer drugs. We hope that in our lifetime we find a drug that can cure the cancer. And if I had to pick a class of drug that may at one fine day lead to a cure, I would hedge my bets in favor of immunotherapy. So all the cures or the few cures that I've seen in my life where patient had a dramatic response to a drug happened to be as a result of immunotherapy drug. Not one type of drug, it could be different type of immunotherapy drugs under clinical trials. And of course, it only worked for one or two anecdotal cases, but immunotherapy has that potential. When it works, it can fully eradicate the cancer. Will that breakthrough happen from CAR T, BiTE therapies, uh, cancer vaccines, oncolytic viruses, combinations, all sort of things? That is time would tell, right? And we're nowhere even close to that. But right now, I don't think immunotherapy is anywhere close to replacing somatostatin analog. But as an eternal optimist and a drug developer researcher, I would like to believe that one fine day immunotherapy will replace everything and will find us a cure.
It's the dream. So this is a big question. What determines if a NET neuroendocrine tumor patient is a good candidate for immunotherapy?
Right. Great question. I would encourage the viewers to also refer back to a webinar we did a long time back where we discussed 101 of neuroendocrine oncology. So there are two types of neuroendocrine cancers, that NET versus NEC. Today's talk was mostly focused on NEC, the poorly differentiated neuroendocrine carcinomas, although some well-differentiated NETs are also being involved in the clinical trial that we discussed. But a well-defined NET, oftentimes there is very limited role of immunotherapy. We have great drugs like lanreotide, somebody mentioned, PRRT, TKIs like cabozantinib, and several others in the picture. Immunotherapy hasn't really made its way in low-grade, well-defined neuroendocrine tumor. Not the case in neuroendocrine carcinoma. So in neuroendocrine tumor right now, very limited role. However, if you do have certain telltale signals like high tumor mutation burden, you will be a candidate for Keytruda. So that would be one indication. But oftentimes we don't use it in NETs. But when it comes to NECs, it is a very important part of our armamentarium, as we discuss SWOG DART 1609, allowed us to use ipi-nivo as standard of care in refractory disease once patient has been through chemotherapies. So in NEC patients, even if you don't have any biomarker, it's worth trying, and I've seen some exceptional responses. But if you have biomarkers like high tumor mutation burden, clearly there is a signal that you may benefit from immunotherapy. So that is why we encourage high-grade neuroendocrine cancers to get a next-generation sequencing to understand different targets, including high tumor mutation burden, to see whether they will be candidate for immunotherapy.
Yeah, thank you. Distinguishing neuroendocrine tumors and neuroendocrine carcinoma is important. And in fact, there was a related question about, is Keytruda used for neuroendocrine tumor carcinoma treatment of the small intestines with metastasis in the liver? And would it be considered for which stage in my disease? So I think there's a confusion here about neuroendocrine tumor and carcinoma. So Dr. Chauhan, would you address this as well?
Yes. So for a neuroendocrine tumor, unlikely to be a role. For neuroendocrine carcinoma, the high grade, which I believe this patient is alluding to, Keytruda can have a role. However, only right now, only by the books, if you have intermediate or high tumor mutation burden, then it is already FDA approved for any cancer. Doesn't matter neuroendocrine tumor or carcinoma. You can have kidney cancer, lung cancer, any cancer. If you have intermediate or high tumor mutation burden, there is a tumor agnostic FDA approval for Keytruda. But if you don't have that, we have had slew of negative clinical trials with Keytruda and similar drugs, nivolumab by single agent and others, which hadn't really panned out. The only silver lining was the ipi-nivo study. So if we are going to do immunotherapy without any biomarker testing in high-grade neuroendocrine cancer, then ipi-nivo is my go-to and is also currently recommended by NCCN in refractory disease.
Right. Speaking of tumor mutational burden, what tumor mutational burden threshold without MMR would indicate immune checkpoint inhibitors in grade 3 with high Ki67 of at 50%? So that was somewhat related as well.
Correct. So usually intermediate and high tumor mutation burdens, the higher in my experience, the better, but I think you need to have at least 10 or more, and I'll have to fact check myself on this later as well. The precise number, is it 10 or 12 or 8 for that intermediate? But in my experience, the higher, especially in the double digits, those are the ones where I had seen great response. Currently have a patient on well-defined grade 3 NET with beautiful response to immunotherapy now going in at least, I think, a couple of years at this point in time. So yeah, it happens, but these are very rare situations.
Thank you. Um, and let's address lung as well. Would immunotherapy be appropriate for lung nets? And does atezo, for short, work for pulmonary large cell neuroendocrine carcinoma or only small cell lung cancer?
Great question. And I think there currently is very limited data, in fact, no data in this area. So what happens is large cell neuroendocrine cancer is a very sister cancer to small cell lung cancer. And I'm seeing over the years, more oncologists are treating large cell neuroendocrine cancers like small cell lung cancers. So because of that extrapolation, atezolizumab is commonly being used, just like how we use it in frontline small cell lung cancer. It is very rare. 1 in 100,000 people have large cell neuroendocrine cancer. It's only 2% of all lung cancers. So to do a clinical trial in just large cell neuroendocrine cancer of lungs will be very difficult, almost a futile attempt. So oftentimes we extrapolate the successes from small cell lung cancer and use that technique in large cell. So you won't be faulted if you are adding atezolizumab with chemotherapy in large cell neuroendocrine cancer for now.
Thank you. Um, this is an interesting question. How does intratumoral immunotherapy and NK cell-based immunotherapy work for NET patients?
The intratumoral immunotherapy, I think the question is alluding to one of the studies we brought out, the Seneca Valley virus study. These are oncolytic virus, as the name suggests, oncolytic. So cancer destroying, lytic is destroying, right? So these are viruses which don't affect us, but affects the cancer cells. And there are different ways to do this. You can inject it through your vein and goes into bloodstream and then infect the cancer cells. But a direct way to infect the cancer cell is directly injecting the viruses into the tumor cells. And then they grow and thrive there and then destroy the tumor and then spill out and then they infect the other tumor cells. So many cancer oncolytic virus therapies, which are in the development right now, are using that technology where they inject the high concentration of these viruses, which are either engineered or naturally kill just the cancer cells into the tumor. Of course, there are some limitations with that. You can't inject all the tumors, so you need to have a tumor which can be accessed through interventional radiologist or some technology. For example, melanoma, Merkel cell carcinoma, which are superficial. Even an oncologist like me can inject it. It's rather easy. But when you're looking at a deeper visceral lesions, liver mets or lymph nodes, you need help from your colleagues from interventional radiology to go under CT guidance and inject these viruses into the tumor. So that's injectable intratumoral immunotherapy or oncolytic viral therapy. NK cell therapy, as we discussed earlier, these are immune cells that are designed by nature to kill anything that is foreign to body. So they are currently in research and are ready off the shelf because you don't have to engineer them specific to the patient. So a lot of NK cell therapies are ready off the shelf, and you can just pull it and infuse it in the cancer patient and hope that this will engage with the cancer cell of those patients and then eradicate them. That's the philosophy behind it.
Yeah, yeah. Well, you've been already alluding to a range of ways of administering immunotherapy, injecting, infusions, but I'm going to open it up to this broader question. What's the medium for administering immunotherapy to neuroendocrine, I'll say neuroendocrine cancer patients, not just NET patients as a
Yeah.
whole?
The most commonly used immunotherapies right now, the ipi or immune checkpoint inhibitor like Keytruda's, they're given through IV. And different drugs have different regimens, every 3 week regimen, every 2 week regimen, every monthly regimens. So just like chemotherapy flowing to IV. The T cell engager therapies, the BiTE therapies or Brixtimig or the standard of care tarlatamab for small cell lung cancer are also IV therapies. So the majority of these therapies are developed just like how we would give IV chemotherapy or any other IV drugs. These are they're infusion, they're infused into the blood supply through the vein. But some of these other nuanced ones that we discussed, like interlesional therapy with oncolytic virus, some of them are designed to inject directly into the tumor cells. Uh, CAR T therapy is also that is infused into the patient. So majority of the drugs are developed the way that we conventionally treat the cancer patients through IV administration.
Thank you. There's questions about who may not be eligible as well. So or maybe, would people with a 30% pancreas, no spleen? What about people without adrenal glands?
Great question. So immunotherapy has very limited contraindication. Again, it's a broad blanket statement. Please, so there, as you heard, there are different type of immunotherapy. So right now, for example, we are talking about, BiTE therapies that are available or the Keytrudas or Ipi that are commercially available that we are treating. So um, for most parts, immunotherapy drugs don't have side effects like chemotherapy. They're not immunosuppressants, right? So they don't put you at added risk for developing infection, opportunistic infections, etc. So they're relatively safe from that standpoint. So somebody does not have spleen and they are already high risk for certain infections like capsulated organism, bacterial infections, immunotherapy is rather safe. There is no contraindication to my knowledge. Where immunotherapy may be a contraindication is autoimmune diseases. So immunotherapy has a complete different type of side effect profile. They can rev up your immune system and make your immune system not only attack cancer, but attack your own body. Have autoimmune colitis, pneumonitis, thyroiditis, adrenalitis, you name it. Anything in your body can be affected. So if somebody has an autoimmune condition where their immune system is already attacking their body, like multiple sclerosis or Guillain-Barré syndrome or something else, bad ulcerative colitis, you have to be very cautious. You have to understand the risk benefit and discuss with your oncologist.
Thank you. There is this is a really helpful question. How long does it take to determine if immunotherapy is effective for neuroendocrine cancer patients?
Yes, unlike chemotherapy, in my experience, immunotherapy does take time to kick in. So patients with high-grade neuroendocrine cancer, they know when they're diagnosed, there's an urgency starting carboplatin etoposide because it works very fast and you see the benefit very fast. Patients report improvement in their symptoms. Immunotherapy, when it's infused, it has to engage with the immune system, cause this immune reaction, activation of inflammation, and then recruit more immune cells and destroy the cancer. So the treatment effect is probably not as quick as chemotherapy. However, we often time do scans every 2 to 3 months to assess. The first scan you have to give a little bit leeway if patient's really doing well clinically, but the scan shows some swelling or growth in the tumor. It could be pseudo progression because immunotherapy is working and it's destroying the tumor. There's swelling around because of that inflammation. So it looks like a false progression. So in immunotherapy world, if you see slight growth, but the patient's doing well, you might want to wait and do another confirmatory scan another month or two after that. So that's a very unique nuance in immunotherapy. And so I usually wait 2 to 3 months for the first scan to make a judgment on the
Mm,
effectiveness of immunotherapy.
Thank you for that. Another question about what might disqualify you. What might disqualify you from receiving immunotherapy? Lanreotide injections, low heart functions, a low ejection fraction, with simultaneous treatments for other cancers.
Immunotherapy drugs are usually well paired with other treatments as well. As you see, atezolizumab is given in conjunction with chemotherapy. So again, I don't want to advocate for just mixing and matching at a whim. If immunotherapy drug has been tested in a particular combination and that's how it's being used, it's very safe to use. Immunotherapy drugs are also very heart or cardio safe, unlike certain chemotherapies, which can affect the heart function. Immunotherapy drugs are not notorious to cause heart issues outside of rare autoimmune side effects. When immunotherapy drugs were very new, we wrote a case report in Annals of Oncology describing autoimmune myocarditis and collated 2022 odd cases from world over at that time. But we are talking about really needing the case that like it's a very rare side effects. For majority of patient, it would not usually deteriorate heart functions, and it can be easily given along with lanreotide. But the question is, why is there a need to do immunotherapy? Because again, in a well-differentiated neuroendocrine tumor patient where lanreotide is the mainstay of treatment, immunotherapy is not the mainstay of the treatment. So I just want us to understand that NEC patients where we do use immunotherapy, there is a role. Within NET patients, there's a very limited role unless you have high tumor mutation burden or some other biomarker that makes you a candidate like MSI high status, etc. So to talk to your oncologist about it, but usually you would not just want to combine SSA with immunotherapy in well-differentiated low-grade nets unless you have a reason to.
Thank you. Thanks for clarifying. And what are the side effects? I know this is a big question again.
We kind of building on what we already said, usually immunotherapy drugs are not cytotoxic drugs. They are not poisonous chemical by itself. They are killing cancer by revving up your immune system and making your own immune system fight against the cancer cells. But imagine a scenario where immune system is so excited and this inflammation is spilling over to not just cancer cells, but is affecting your normal cells. So the common side effects are autoimmune thyroiditis. You can have hypothyroidism, which is very easy to treat. We don't even stop immunotherapy for it. We just treat, we treat it with synthyroid or thyroid replacement, hormone replacement. Autoimmune pneumonitis, if starts affecting your lungs, you may have shortness of breath, like pneumonia-like symptoms, and if but any organ in the body can be affected. Another common one is autoimmune colitis. So if you have bad diarrhea, autoimmune dermatitis, you have a rash. Again, based on how severe the symptoms are, you can treat with immunotherapy and maybe give topical steroids. But if it's really bad, you have to stop the immunotherapy. And the common antidote is steroids. Puts the brake on the inflammation. So if you have autoimmune colitis, autoimmune pneumonitis, or any autoimmune itis from head to toe, you're going to stop the immunotherapy drug. You're going to give high dose steroid, maybe 2 weeks, 3 weeks, 4 weeks, based on the severity, and go from there. And then there are other, even more stronger immunosuppressive agent in select condition that your doctor may give it to you based on the need of the hour.
Thank you. Thanks for clarifying. How long can someone be on checkpoint inhibitors, and what about combination of checkpoint inhibitors and TKIs?
Um, One of my longest patient on checkpoint inhibitor and still going strong is now over 5 years or maybe 6 years at this point
Wow.
in time. And again, this is the patient who had a good response and don't want to give up and has no side effects. I've also had a patient who had complete response after 3 years and decided, Doc, I don't want to continue it. Let's continue to watch closely without the treatment. So it really is an uncharted territory when you go so far out, and it's basically, I would encourage patient-centered conversation, what patient feels more comfortable doing. But as long as it's not hurting you and as long as the treatment's working on the scans, things are stable, you want to continue it as long as possible. Combination with TKIs, there are a lot of trials, including some in even neuroendocrine space. I think one of the trials open at UCSF where Keytruda is being combined with one of the TKIs, and there is a theory that TKIs make cancer cell respond to immunotherapy better. And there's a good preclinical data to support that theory. We are going to see if that pans out in human trials. So yeah, stay tuned. And these combinations being investigated in a lot of different cancers, including neuroendocrine cancers.
Thank you. And a related question, what therapies may work in combination with immunotherapy? I know you mentioned TKIs, and what else, if anything? Yeah.
So, as I alluded to in my talk, immunotherapy has been such a game changer. Two fantastic scientists got Nobel Prize for discovering this mechanism and drugs, henceforth. So you can imagine anything and everything is being combined with immunotherapy. There was a big wave of immunotherapy. Currently, immunotherapy is being used to treat several cancers, probably 30 different type of cancer, or not more, maybe. So when you have a drug that works so well, there's always a wave of research. What can be combined with this drug that already works well to make it even better? So you will see that there are trials with combination radioligand therapies, combination with TKIs, combination in oncolytic viruses, combination with chemotherapies, you name it, combination even with T cell engagers. Nothing is, off the bat. Some of the combination will work really well, and other combination will find that they're too harsh or too toxic, and time will tell. So I'll give you an example. Atezolizumab was tested in combination with chemotherapy and turned out to be success in small cell lung cancer, is now the mainstay how we treat small cell lung cancer in frontline therapy. So there are hundreds of trials. I'm not even kidding. Hundreds of combination trials with immunotherapy in all cancer oncology space. Too many for any human to know. Probably ChatGPT can pull a whole list for us.
Yeah. And of course, we have that Ancora AI tool as well to search for neuroendocrine cancer trials. Thanks to the team, Josh Mailman and the Ancora team. So this is an interesting question. If someone had benefit, say they had melanoma and they had a good response to immunotherapy, is there any likelihood their neuroendocrine cancer also has good receptivity for a response?
Um, well, these are two distinct cancers. And although it's very, I'm glad to hear the patient had a good response to melanoma, but melanoma has been the huge, biggest success story with immunotherapy. And most patients actually benefit from immunotherapy in melanoma. How much would that spill over to high-grade neuroendocrine cancer? I don't think we can take it for granted. I think it's worth investigating for sure. As we've seen patients, there are 20-30% patients based on the SWOG DART study that do benefit to immunotherapy. But I would not automatically take the win from melanoma because we already know immunotherapy works very well in melanoma. And we also know that many patients with high-grade neuroendocrine cancer don't respond to conventional immunotherapy. So I would be somewhat optimistic, but I would also be cautious and let the first couple of scans kind of really prove our hypothesis is going to help or not. But there's no direct correlation between these are two independent cancers with independent efficacy of immunotherapy in their own domains.
Right. So I know this answer, your answer may only be speculative, but what's your best estimate on when in years immunotherapy will be a standard treatment option for neuroendocrine cancer?
Well, to be honest, right now it is already a standard. We've been using Ipi-Nivo. NCCN guidelines has adopted, which is considered as a standard practice manual in the United States at least. So many NEC patients are already been getting Ipi-Nivo for past few years. So I would argue it is already standard of care in some patients. We also have Keytruda that has been approved for all cancers, including neuroendocrine cancers, as long as you have intermediate or high tumor mutation burden. So to answer, we have currently using immunotherapy, but the question is probably what the uh, person was trying to ask is the newer immunotherapies. We are talking the T cell engagers, etc. I think right now we are waiting for a randomized phase 3 study like the one that Amgen did in small cell lung cancer and led to its FDA approval in small cell lung cancer. So we need to do a similar study in high-grade neuroendocrine cancer to get the BiTE therapy or DLL3 T cell engager approved. But there is work in progress. Stay tuned. I am speculating maybe 2 years, 3 years max.
Thank you. And I know you started talking about the DL3 ADC trial. So if you could, there were two questions about this, about the Xylive trial. Um, what do you know about this, and what's the difference between the DL3 T cell engagers and the ADC trial?
Yes, so the only common denominator is that these drugs are all targeting DLL3. Right? That is the only commonality, but they're vastly different. Outside, once you have a drug that targets DLL3, how it's targeting? Is it engaging the T cells, your own immune cells, to fight the cancer? Or is it a chemotherapy drug that is loaded into this drug that is sticking to the DLL3 positive tumor? That's called ADC, antibody drug conjugate. So again, these are different technologies. The only commonality is that they target DLL3. But outside that, no doctor can comment on which one's better. Should you even compare the two? Because it's like comparing, honestly, a train to a ship. Just because their mode of transportation, they are very different modes of transportation. They'll have different utilities. I think both will more options for our patients, the better it is for our patients. But there is no way you can compare all these different drugs. Again, these are just the two examples I gave. There are several others. There are radiopharmaceutical drugs. There are T-cell engagers. There's so many other agents that will be designed to target DLL3 because it's such an attractive target in high-grade neuroendocrine cancers.
It's just the beginning. So we'll end with this last question. A couple of people asked similar things, and they may have heard us say this in the introduction that you're relocating from Miami to California. Dr. Chauhan, is it true you're moving to California, and where can we find you in California? And more importantly, will you be taking your clinical trials to California with you?
Well, the news traveled very fast in neuroendocrine circles. It is true. I am looking forward to the next chapter of my academic career. I'm very happy to join the faculty at University of California, San Francisco, which already has such a fantastic neuroendocrine cancer program. And I will continue to focus a lot of my clinical and research duties in developing treatments for both low-grade as well as high-grade neuroendocrine cancers. This move is slated to take place in January of 2026. So stay tuned, Google me, and there should be a link to access how to see me either remotely or in person in January 2026.
Thank you so much. So lastly, I know we're at the end of our time. Could you share a little bit about the survey that you and I have been working on, the Voice EP patient survey, and the other opportunities for people to take action and share their voice to move the field forward?
Thank you, Lisa. Thank you for reminding me of that important endeavor. As we have seen, advocacy is very, very important to help advance the field. We've seen this happen in low grade and well-differentiated neuroendocrine tumor 10, 15 years back, very limited treatment options. Patients often had to travel outside the US to get drugs like PRRT. But a concerted effort from patient advocates, advocacy groups, academias, industry really catapulted the field forward. And we now have so many drugs. I often have patients who travel from outside the US for an opinion or a clinical trial. We need to do that for neuroendocrine cancer or high-grade neuroendocrine carcinoma patients. These are truly unmet need patients. They have no treatment options, very limited treatment options, and very poor outcomes. So Boehringer Ingelheim is really focused on advocating for these patients, and they've collaborated with academic partners. I'm one of them. Dr. Jason Stern from Mayo Jacksonville is another one, and several very prominent, prolific patient advocates. And Lisa is one of the loudest voices for the patient advocacies out there in the United States and abroad. So we have collaborated together and have designed this very extensive, detailed questionnaire. We'd like to study what the patients experience in this journey of neuroendocrine cancers, the high-grade neuroendocrine cancers. And this understanding would also help us understand how to develop better drugs, where is the unmet need, and there will be a wealth of data. There has never been a study of this nature and this bandwidth in high-grade neuroendocrine cancer space. And there is also it's a very extensive questionnaire and is available to all extra pulmonary neuroendocrine carcinoma patients. And there is some compensation for your time spent helping this survey. So I would really urge and request anybody who you know who is had experience with extrapulmonary neuroendocrine carcinoma, please share this survey. You can find the link of the survey at the Neuroendocrine Cancer Foundation website and help us make this study successful, because what we learn from this survey will then set up the next generation of research in this space.
Absolutely. And this is a team effort. We're all in this together. It's going to take all of us to move this field forward. So a collaborative effort across organizations and across institutions. So this month and next month, we're looking at a survey for patients. Then there will be launching a survey for caregivers, and then another one for healthcare providers. And the more voices, the better. So this is our opportunity to take action and share your voice and experience. So thank you, Dr. Chauhan, for leading this effort and for everyone who is contributing. We just want to thank you again, Dr. Chauhan, for all you're doing in this field. There was someone specifically who said, thank you, Dr. C. As always, you provide such great information for us. Thank you so much.
Thank you
Really,
so
your
much. Thank you
passion,
for the
dedication,
opportunity.
it gives us all hope. So thank you so much. And now I'm going to turn it back to Heather in the studio.
Thank you. Thank you so much. And also a big
Thank you again, Dr. Chauhan, for your enlightening presentation and addressing the interesting topic of immunotherapy. We appreciate our supporters, Novartis, Ipsen, Exelixis, Crinetics, Curium, ITM, Boehringer Ingelheim, Tercera Therapeutics, and Inner Science Institute. Educational programs like today's are also made possible by donors like you. Please consider making a donation today at ncf.net/donate. And a special thank you to our technical director, Rich Tamayo from TVP Live, for this high-quality broadcast production. Again, today's presentation and live Q&A session have been recorded and can be viewed on our website and YouTube channel shortly after this broadcast. If you're registered for today's webinar, you may receive a survey via email. We would greatly appreciate you completing this survey as it helps us improve our content. To receive our reminders and newsletters, be sure to add events@ncf.net to your Save Sender contacts and whitelist email lists. Again, follow us on social media to stay up to date on our upcoming educational events. Our handle is @NCFCancer. And now I'll turn it back over to Lisa.
The Neuroendocrine Cancer Foundation is a community of support and resources. We recognize that you are more than your disease, and we aim to support you as a whole person. To this end, we offer many resources and programs. Find out more on our website, ncf.net. We offer a monthly podcast featuring experts who answer the top 10 questions in their field. Go to our podcast page to check out the episode transcript, resources, and the questions we ask the expert. Join us for a future event. Our virtual event next month will be Wednesday, January 21st, on the latest in management of functional neuroendocrine cancers with Dr. Hidero Del Rivero. Please join us and save the date for Saturday, May 16th for our in-person patient education conference in Atlanta. We hope to see you. Thanks again for joining us today. Goodbye, and we look forward to seeing you at our next event.
Oh my goodness.